Okay, hello and welcome to the second session of today's first day of the P&O conference. Apologies again for the slight technical issues we were having earlier and the delay, but everything's back on track now. This second session is focused on developing care in AFO care. We've got two great speakers for you. So first up is Dr. Nicky Eddison, who this year has become both the first consultant orthotist in the NHS and an associate professor. Her research interests include the biomechanical optimization of AFOs, gait analysis and digitalization of healthcare and health inequalities. She's here today to present the latest research on developing a standardised classification system for bespoke thermoplastic ankle foot orthoses. Following Nicky, we'll then have George Coles, who's a senior orthotist at the London Orthotics Consultancy. George has managed in and outpatient clinics at the Queen Mary's and King's College Hospital and specialises in musculoskeletal and foot and ankle conditions, scoliosis, adult and paediatric neurorehabilitation, and orthotic treatment of the diabetic foot. He's here today to present on the optimal segment kinematic alignment approach to the rehabilitation with patients with cerebral palsy. Just a quick reminder of how this session is going to work. Each speaker will be delivering a short 25-minute presentation, followed by the 5-minute Q&A. Please put any questions you have on the live chat system, and we'll try and get through as many of these as possible. I'd just like to invite Nicky Eddison to start sharing her screen, and we can begin.
Thank you, Sean. I'll just share my screen now. Is that sharing, Sean?
Yeah, can see everything and hear you, so it's fine.
Okay, thank you. And thanks for inviting me to share some of our research today. So as Sean said, my name's Nicky, but I'm part of a wider research team, including Aoife Healy, Dave Buchanan, and Nachi Chokalingam, who all worked on this study. So we may as well start with why we prescribe AFOs in the first place. So we prescribe AFOs to control motion, correct deformity, and compensate for weakness. And the first known reference I could find in the literature for AFOs dates back to 1791. And you can see the picture there, and it looks very familiar to what we use today. But apparently this was made from tin, which makes sense because it's lightweight and it's moldable. So standardisation. We do have a standardisation for the term AFO. That's been standardised by the International Organisation for Standardisation, ISO, and they define it as an externally applied device used to modify the structural and functional characteristics of the neuromuscular and skeletal system. There are several ISO standards, and within them they offer information on functional deficiencies, clinical objectives of treatment, functional requirements of the orthosis, and categorization and description of external orthoses and their orthotic components. So if we have these definitions and these standards, then what's the problem?
Are you still there, Nicky? I think we just lost connection. Sorry, you're back, Nicky. I could you just muted. Sorry, you're still on mute, Nicky.
Okay, I think I'm unmuted. I don't know how that happened. So where did you hear up to?
It was, I think, the slide that said the problem.
Okay.
It froze on that slide.
Okay. So I'll go back over that then. So if we've got a standardization for
Sorry,
AFOs.
just before you begin, so that you're not sharing your slides if you're going to share them again.
Oh, okay. I am sharing, but I'll come back out of it again. Try again. Any better?
Yeah, I can hear you and we can see the slides. But yeah, we're all good to go, I think.
Okay, success. Okay. So I'll go back over that then. So I said, if we've got a standardization and definitions for the term AFO, then what's the problem? So the problem is that these definitions and standardizations only apply to the term AFO and the components of that AFO. There are no definitions for the different types of AFOs that we prescribe. The standards do indicate that AFOs can be classified according to the function and the type of fabrication, but what it doesn't say is what terminology we should be using for such classifications. So the wonderful Elaine Owen and myself have both recently written about this issue, and we've both come to the same conclusion that standardized terminology and definitions for AFOs are critical in clinical practice. And without these, there may be serious negative consequences with the potential to cause harm. So I think we're all unequivocal that AFOs are not the same. There's all different types of AFOs and there are all different names for them. So here's an example of all the different types of AFOs, and it's not exhaustive, there's just a sample. And if you have a look at some of the names here that we use, and these names have been taken mainly from the literature, you can see that we've got solid AFO here, and probably most people are thinking, yeah, I know what a solid AFO is. So I asked my team, what's a solid AFO? We're a team of 7 orthotists in our service. And I said, what's a solid AFO? And most of us had the same definition. One of us said, it's an AFO made from a solid material. And therein lies the problem. We think we're all singing from the same hymn sheet, but we're not. And if you go to America, they have something called a floppy solid, which would be something like this here, which is an AFO with the trim lines anterior to the malleoli, which I would consider a solid to be something that doesn't deform during stance phase. However, they use the term for this design, but something that deforms during stance phase. So you're starting to see the problem. If we have a look at some of the other names that we use, we've got here a modified standard. So if you haven't got a standardization for this, then what's a modified standard? Same with standard articulating AFO. So this would be considered an articulating AFO, so would this, and so would this. But they're all different, and they're certainly not standard. So that's the problem. And that leads to confusion in the literature. So here's a couple of papers that we've published on this area, and I'm going to concentrate on this one in particular. Do research papers provide enough information on the design and material used in AFOs for children with CP? This is a systematic review we did back in 2017. Now, it's worth bearing in mind here that the AFO was the main intervention studied in these papers that we reviewed. So bear that in mind, it's the main intervention studied. Yet there are 26 different names used for the AFOs, some people using different names to describe the same AFOs. None of the papers reviewed gave a full description of the AFO studied, and none of the papers gave a justification for the AFO prescription. So let's go back to that point in red. It's the main intervention being studied. We're using different terminology, we're not describing it, and we're not describing the people we're putting it on. So how can we draw conclusions from this research? Now, there's three problems here that I see. It's terminology, it's description of the AFO, and it's a description of the patient. Now, work from Emily Ridgewell in 2010 and Roy and Karen, Bowers and Ross in 2010 with their best practice statement. They all have already said for the past decade that we need to be describing these AFOs and we need to be describing the patients we're giving them to. So that's not new. This is building on their work. But what I'm focusing on is the terminology we're using for the actual AFOs themselves. So there's another similar paper by Figueroa et al., the efficacy of AFOs on gait of children with CP, another systematic review. And they reviewed 20 studies. They found 12 different terms used to describe the same AFOs. And the paper reported that the variety and the types of AFOs and the descriptors made it difficult to summarize the results. So we knew there was a problem. And we ask ourselves, what is the result of this confusion? Okay, I might not know what you're talking about when you say solid AFO, or when somebody says ground reaction force AFO, we may have different understanding, but what does that actually lead to? What are the implications? There's a couple of implications. One is not being able to draw valid conclusions from the research, but the other implications are things like this. So if we look at the current NICE guidelines for spasticity in under 19s management, it states, for children and young people with Aquinas deformities that impair their gait, consider a hinged ankle foot orthosis if they have good control of knee or hip extension. And as a professional body, we did challenge this at the time. And NICE came back to us and said, that's what the literature shows. And that's the problem. You're drawing conclusions from poorly designed research. Okay, so we went about looking at how we can get some kind of standardization for the terminology of the names we use. And we devised this classification system. Now, before I go in and describe why we chose each of the names for each of the categories, it's just worth pointing out here that on the rigid AFO section, we have made it clear that the material should not deform during stance phase. And here in the information that goes with it, it clearly states AFOs can have different combinations of medial lateral flange lengths on the foot plate and different foot plate lengths and strapping systems. So none of those things would change the classification of that AFO. It's also worth noting that this system is for bespoke thermoplastic AFOs. So why did we choose these terms? Well, we chose rigid AFO rather than solid and other names used because rigid is an expression of stiffness. We chose flexible AFO because it aligns with the term used in ISO, and it's important to try and align with the terms used. We chose articulated AFO because, again, it aligns with the term used in ISO, but also not all articulations have hinges. We chose rigid AFO with separate anterior shell rather than the more commonly known ground reaction force AFO or GRAFO or GRO because it aligns with the ISO standard, but also because there is no evidence to show that putting an anterior shell on an AFO affects the ground reaction force any differently. And again, with the rigid AFO with incorporated anterior shell, the reasoning was the same as the previous one. And we use supramallear AFO rather than the commonly termed DAFO, because dynamic is ambiguous and there's no clear definition of what is dynamic about the orthosis. So we devised a questionnaire with a global consortium of participants, 63 in total, and they included physiotherapists, orthotists, researchers, and orthotic technicians from 13 countries around the world. So the first aim was to determine the inter and intra-observer agreement between the photographs of different AFOs and how they were classified using the classification system, using an online questionnaire via Qualtrics. The survey was repeated 2 weeks later with photos in a randomized order. So in essence, there were 36 photos of each category, 6 categories, and we asked the participant to look at the photograph of a real AFO, and they had a multiple choice of saying this is either a rigid AFO, this is a supramallear AFO, etc., using a classification system. And then 2 weeks later, we randomized the photographs and we asked them again. Along with that, we asked them a few questions, including if they were aware of any classification system which provides names for different types of bespoke AFOs, if they thought there was a need for the classification system, if they thought the presented classification system was clear, and their ease of use. So let's have a look at the results. So to the question, do you know of a classification system which provides names for the different types of bespoke AFOs? 15 said yes, 48 said no. For those that said yes, we asked them if they could name the classification system. 9 gave no response, and 6 gave names of AFO systems that weren't classification systems. So quite a few mentioned Elaine Owen's algorithm for AFO tuning. The next question, do you think there is a need for a classification system for the different types of AFOs? 47 said yes, 3 said no, 13 said they were unsure. If the participant answered no or unsure, we asked them why there might not be a need, and we got no response. We asked, do you think the concept of the AFO classification system is clear? 57 said yes, and 6 said no. We asked, having used the classification system, do you think it will be useful in standardizing the terminology to describe bespoke thermoplastic AFOs? 53 said yes, 2 said no, and 8 were unsure. When we asked those that said no or unsure why they think that it might not be useful, we got no response. We asked, would you use the proposed classification system again? 54 said yes, 8 said no. Of those that said no, we asked them why they wouldn't use the system again. And this was an open-ended question, and the answers focused on not having enough categories. Well, I think this is a starting point. I think it's possible that you can add more categories. Not including all the trimline permutations for the foot plate. So that was stated on the classification system that wouldn't change the classification system. They said they would rather use a local classification system, which I guess is fine, but it's why we have this issue in the first place if we're all using local classification systems. And one of the technicians said it would lead to clinicians ordering a rigid AFO with no spec described. So they was concerned they would just get orders saying rigid AFO and they wouldn't know how to make it, which I would be surprised if that happened, but I think if it did happen, that would be probably a training issue, because obviously this is not a prescription algorithm. It's merely terminology for the name of the AFO. You still have to design which AFO you think is right for your patients and with which permutations of the design you need. So we looked at the Intraobserver agreement, and this is the agreement between participants. So this is where they looked at the photos and classified them, and there was excellent agreement between the participants with a kappa flies of 0.932 with a 95% confidence interval. And the Intraobserver agreement, that was also excellent with 0.944 a kappa flies. So interpretation. According to Landish and Koch, the inter and intra-observer agreement of the kappa values from this study are classed as almost perfect. 98.3% of the participants found the classification very easy or moderately easy to use. And 90.5% reported that the classification system is clear. So to conclude then, we would suggest that the classification system should be used as a basis for all bespoke thermoplastic AFOs to negate the ambiguity of the current non-standardised terms, and for people to take this forward, and if they can improve the classification system or add to the classification system, great. It's a starting point and we need a starting point. There's no current classification system in the literature for bespoke thermoplastic AFOs. This new system is clinically relevant to improve communication between healthcare professionals. It will allow meta-analysis of AFO research, and ultimately, it will improve the treatment of AFO users. Thank you for listening, and if you have any questions, I'll be happy to answer them, I think, at the end, whenever they're scheduled. Thank you.
Hi, Nicky. Thanks for that. I think we're going to do the Q&A for you now, and then we'll move on to George's talk, so it's just sort of flows a bit better. We have got a couple of questions. So I'm sort of personally involved in research in this area. This is sort of my field. How do you plan to actually ensure like the impact of this standardisation is actually felt? You know, you mentioned Ridgewell's papers and a couple of other papers, and they've been best reporting guidelines have been made, but it hasn't actually necessarily been uptaken very much in research. I'm just wondering what your plans are.
So this paper is under peer review at the moment, but really, if we want it to be taken forward, we need the main stakeholders to back it. So it would be great if ISPO backed it. It would be great if the universities who teach the undergraduates back it. I did a presentation at Kiel seminar, so they're doing the master's P&O course that starts in January, and they're happy to start using this. So that would be great if they could do that, because if you get the undergraduates used to using this terminology when they come into practice, then this is hopefully the terminology they'll keep using. But I think you need wider stakeholder input. I think to be realistic, that's what you need.
Okay. Yeah, we've sort of had a similar question saying how to encourage awareness and the adoption of the classification. I think you just sort of quite nicely covered that. Also, you spoke of how you excluded trimline permutations from the classification system. Was there a particular reason behind that, and why that wasn't? Because as I'm aware, it can affect sort of mechanical properties.
Yeah, there was a reason. I did look at it at first, Sean. When I first did it, I did all the permutations, and my head was spinning. I was like, this is just never going to work. You have to simplify it. And when I looked at it, I thought, well, actually, a rigid AFO with the trim lines anterior to the malleoli with no deformation in stance should be standard for a rigid AFO. If you want to block the third rocker, bring the flanges forward. If you don't, push them back. That's patient specific, so you can have all kinds of permutations that maybe put the medial one back and the lateral one forward, depending on how your patient presents, but the main design of the AFO remains the same. Same with the strapping system. If you're using a figure of 8, or if you're using a Velcro crossover, a loop, whatever it may be, they can change, but the design stays the same. So I think, to be realistic, for it to be simplified for people to take it on and to start having some kind of standardization, you've got to keep it simple. And I think if you start using all these different terms, then all these different classifications need a name. So then you're going rigid AFO with what you're saying lateral flanges anterior, and medial flanges posterior, and then you've got 3 or 4 permutations just for that. And then you'd look at the strapping system, and all of a sudden you've got almost 50, 60 different, and probably nobody's going to take that on. So I think realistically, we keep it simple where the design doesn't change. And then if you are describing your AFO, if you were going to do something different to it, something unique, we'll know what you're talking about. If you said, I use a rigid AFO and I added this, this, and this, then at least we know where you're coming from. But to use the term standard AFO, nobody knows what that is. So I think Ridgewell and Roy and Karen's work is still important. You still have to describe what you're doing in anything, whether it's a research paper, whether it's your clinical notes, you still have to fully describe it. Just the terminology, if we could standardize that.
I think that's all the questions we have for you, Nicky. Thanks for coming on. It's really interesting.